You are sitting in your clinic, running 20 minutes behind, and your next patient's chief complaint is the most dreaded word in medicine: fatigue. It is the black box of primary care. Is it depression? Is it occult cancer? Is it sleep apnea? Or is it just modern life? Most doctors order a TSH and a CBC, and when those come back normal, they are stuck. But not us. Today, we are going to use a battle-tested algorithm to turn this vague symptom into a concrete diagnosis. We will show you exactly how to filter the dangerous from the benign in under 10 minutes.
Hello everyone, I'm Dr. Matthew.
And I'm Dr. X. Welcome back. We are breaking down this comprehensive fatigue algorithm on your screen. This is your roadmap. We are going to move from immediate life threats to the subtle metabolic causes. Let's dive straight into step 1.
We start right here at the top left. Phase 1. Initial triage and safety, the don't miss phase. Dr. X, this is where we have to stop thinking like a listener and start thinking like a detective. We need to categorize the timeline immediately.
Precisely. Look at step A. Define the timeline, crucial context. The duration is your most powerful diagnostic tool. First branch, acute fatigue, less than 1 month. If a patient has been tired for 3 weeks, do not diagnose chronic fatigue syndrome. You must think infection, acute stress, drugs. This is viral, mononucleosis, acute hepatitis, or a new medication side effect. But move down to prolonged fatigue, 1 to 6 months. This is the danger zone. Here, we think subacute infection, malignancy. This is where endocarditis or lymphoma hides. Finally, if they hit the chronic fatigue, greater than equals 6 months, mark, that is when the differential shifts to think autoimmune, CFS, psych, metabolic. Clinical pearl. Forever is not a timeline. Ask the patient, when was the last time you felt 100% well? That date is your anchor.
Once we have the timeline, we move to step B, rule out red flags, immediate investigation. These are the do not miss signs. First up, unexplained weight loss. This screams malignancy per terabyte hyperthyroid.
But distinguish this from depression. In depression, patients lose appetite. In malignancy or hyperthyroidism, they often eat but still lose weight. Next is lymphadenopathy, mass, which points to lymphoma, metastasis. Always feel the supraclavicular fossa. A node there is never normal. Then we look for night sweats, fevers, indicating infection, B symptoms. Remember, true night sweats mean drenching the sheets, not just feeling warm. We check for dyspnea, chest pain, because fatigue is often a cardiac equivalent for CHF, COPD, ischemia, especially in women and diabetics. And finally, focal neurologic deficits, which could mean stroke, MS, tumor. If a young female presents with fatigue and a history of blurred vision, think MS.
If those red flags are clear, we move to the orange section, phase 2, history and physical, the clinical detective. This is where we look for the saboteurs we often overlook.
We start with check 1, medications and substances, iatrogenic. We often cause the fatigue. Look at the list. Beta blockers, the #1 culprit in cardiac PTS. Lipophilic beta blockers like propranolol cross the blood-brain barrier and cause significant lethargy. Switch them to a hydrophilic one like atenolol if possible. We also see sedating antihistamines, anticholinergics, antidepressants, benzos, opioids, and obviously, substance abuse, withdrawal. Don't forget caffeine withdrawal. It looks exactly like the flu.
Next, we investigate, check 2, sleep and lifestyle, physiologic. This seems basic, but you have to ask specific questions. We look for obstructive sleep apnea. You know the triad: snore, stop breathing, high BMI. But Dr. X, a huge pitfall is the thin patient with retrognathia, a small jaw. They get apnea too.
Correct, and don't dismiss Poor sleep hygiene, shift work. I had a patient working night shifts for 20 years asking why he was tired. That is physiology, not pathology. We also check overtraining syndrome in athletes. If a runner's resting heart rate jumps 10 beats per minute, they aren't improving, they are crashing.
Then we move to the exam in check 3, focused exam findings. We are hunting for thyroid enlargement nodule, cardiac murmurs gallops, S3, which suggests heart failure, wheezing crackles, and pallor, anemia. A quick tip: check the palmar creases. If they are as pale as the surrounding skin, the hemoglobin is likely below 7.
Now, if phase 1 and 2 are non-diagnostic, we open the green box, phase 3, the laboratory screen, evidence-based. Note the disclaimer: only proceed if phase 1 and 2 are non-diagnostic. Do not just order everything.
We start with Tier 1, universal screening for everyone. This is the standard battery. CBC plus diff, anemia, infection, malignancy. ESR, CRP, hidden inflammation, autoimmune. This is vital for catching polymyalgia rheumatica in the elderly. TSH, hyperthyroidism.
Pitfall on TSH. If the fatigue is severe but TSH is normal, ask about headaches. You might be missing central hypothyroidism where the TSH is inappropriately normal but T4 is low. We also run A, CMP, electrolytes, glucose, Ca, renal, liver. Look closely at calcium. Hypercalcemia causes bones, stones, groans, and fatigue is the moan. Finally, CPK, if muscle pain, weakness present, to rule out statin-induced myopathy.
If Tier 1 is normal, we go to Tier 2, targeted testing, risk-based. Do not order these blindly. If joint pains, check ANA, RF. If sexual risk, IV drug, screen for HIV, Hep B, Hep C. If endemic area, look for Lyme, coccidioidomycosis. And the one Dr. X always emphasizes: if GI symptoms, run a celiac screen, TTG-IGA.
Celiac is the great masquerader. You can have celiac disease with zero diarrhea, presenting only as iron deficiency anemia and crushing fatigue. If you see low ferritin for no reason, check for celiac.
Now, we arrive at the most challenging part of the chart. The patient has been tired for more than 6 months, labs are normal, and they are suffering. We are at step 4, phase 4, chronic fatigue evaluation, symptoms greater than equals 6 months.
Here, we stop hunting for organ failure and start phenotyping the syndrome. We have 3 paths. First, path A, the pain-dominant phenotype. The feature is widespread pain above, below waist. On exam, you find exam, tender points, 11/18 positive. If this fits, the diagnosis is fibromyalgia.
The second path is path B, the mood-dominant phenotype. The features are anhedonia, sadness, anxiety. We use validated tools, PHQ-9, depression, and GAD-7, anxiety. If these are positive, the diagnosis is a psychiatric etiology, treat and refer.
But here is the diagnosis of exclusion. Path C, the systemic exhaustion phenotype. We apply the CDC Fukuda criteria. Look at the major criteria required: 1. Severe fatigue greater than equals 6 months, 2. Not due to exertion, 3. Not relieved by rest, and 4. Reduces activity level significantly.
But you need more than just being tired. We need to check the minor symptom count, the decision maker. Look at this list closely. The most specific one is post-exertional malaise, PEM, key sign. This is when a patient exercises and feels destroyed for days afterward. Other signs are unrefreshing sleep, brain fog, memory concentration, muscle joint pain, with swelling, sore throat, tender lymph nodes, and new headaches.
We count these up. If greater than equals 4 symptoms present, we confirm the diagnosis to chronic fatigue syndrome, CFS-ME. The treatment note here is critical. TX, CBT, graded exercise, caution, symptomatic. The word, caution, is there for a reason. If you push a CFS patient too hard with exercise, you will trigger a crash due to that post-exertional malaise.
And, if less than 4 symptoms present, the diagnosis is diagnosis to idiopathic chronic fatigue. This effectively means we don't have a name for it yet, and the plan is TX, regular follow-up, reassurance, monitor.
Fatigue is a puzzle, not a dead end. By using this phase 1 to phase 4 approach, you validate the patient's suffering and ensure you never miss a cancer or an infection, while avoiding the million-dollar workup for simple causes.
Thank you for watching. You can find the link to this chart in the description below.
If you found this breakdown useful, hit that like button. It helps the algorithm, and it helps us reach more colleagues. Subscribe for more high-yield clinical reviews, and we will see you on the next rounds.